في فيلم ريدنج سيشن. هنتصرف ازاي؟ واحد واحد ولا جماعة ولا أنا اللي أجاوب؟ طيب ماشي، نتوكل على الله. أنا هتكلم بالإنجليزي عشان الناس التانية تستفيد يعني إن شاء الله. Number one, we have to mention the examination type. And we have to say that this is a CT scan of the brain. And is it with contrast or no contrast? No contrast. And what do you think about this lesion? If it is without contrast, it cannot be a meningioma at all. Hemorrhage. Yes. And this is hemorrhage. Anywhere. Epidural, subdural. Epidural or subdural? Epidural. This is epidural blood because it is adherent to the inner table, and the inner border of the lesion is convex. And I have said that the blood which is going along the inner border of the inner table, if it has a convex inner margin, then it will be in the epidural space. If it is a concave inner margin, it will be in the subdural space. And this is epidural hematoma. And we also said something about this relative hypodensity within the hematoma itself. And how can you explain this? Yes, so this is hyperacute blood, and this sign is known as a swirl sign. Whenever you see a blood which looks like water, I mean hypodense, intermingled with the blood in the hematoma, then you know that this is acute, hyperacute blood, and this is acute blood. This is epidural hematoma. No, and yeah, the epidural hematoma, as written in the books, it may not cross the suture, but it can cross the midline. If it is near to the midline, it can go to the opposite side. But epidural hematoma, if it is due to arterial bleeding, it will cross the suture. If it is due to venous bleeding, it will not cross the suture, and this is not an absolute fact.
When you said interest or not interest?
If you want to know, you look to the vessels. Like in this case, if you want to know if the patient is injected with contrast, you will see enhancement of the superior sagittal sinus. Here, you do not see enhancement. This is the density of the forks. And with contrast, you may see also some of the vessels enhancing on the cortical surface of the brain. And it should be written, of course, on the film if this patient is injected with contrast or not. Then the second case is what is this exam? This is an axial CT scan of the brain soft tissue window after injection of contrast material showing intraventricular homogeneously enhancing mass in the atrium or the trigone of the right lateral ventricle. Yes, it looks an adult. This patient looks an adult. Yes, the most common homogeneously enhancing intraatrial ventricular tumor is the meningioma. And the meningioma will show most of the criteria of meningioma, like homogeneous enhancement, a smooth margin, may contain calcium. This edema around the tumor is due to trapment of the occipital hole. The meningioma will occlude the CSF flow from the occipital horn, and it will diffuse around the ventricle. And you know that most of the intraventricular tumors are not associated with edema because they are not touching the brain barrier. And this is not an actual edema. This is CSF going in the opposite direction, what is known as transependymal retrograde CSF flow, which is one of the well-known facts considering intraventricular meningioma. If it is small, it will not be surrounded by this hypodensity. Then the exam is axial CT scan on the brain, soft tissue window, after injection of contrast material. The lesion? Yes, there is an oval-shaped, marginally enhancing lesion in the right frontal lobe, surrounded by perifocal brain edema. The enhancing margin is of uniform thickness, suggestive of a brain abscess. Okay. The exam is axial MRI of the brain, T1 and T2 weighted images. Okay. Yes, and this is adrenoleukodystrophy. There is abnormal white matter signal, especially located around the trigone of the lateral ventricles and in the occipital area, bilateral and symmetric, low signal in the T1, high signal in the T2, and if you inject contrast material, it will show marginal enhancement, and this is diagnostic of adrenoleukodystrophy. And you have to say first, what is this examination? Please.
CT scan, sagittal.
CT scan, this is not a CT scan. If you say CT scan in the exam, you will lose half of the mark. Okay? And this is MRI of the brain, T2 weighted images, axial, sagittal, and the corona. The lesion. Okay, multiple, variable sized, periventricular, white matter, foci of high T2 signal, not surrounded by edema, and exert no mass effect. And this age of the patient is diagnostic of MS. What is the exam? This is MRI axial flare weighted image showing a very dark lesion in the frontoparietal area surrounded by a rim of high signal, and this is flare image. CSF is not black in the flare. Can you see it? Fat. I have repeated this many times, that the acute blood will appear of intermediate signal in the T1 and very dark in the T2 and the flare images, and they will be surrounded by a rim of perifocal brain edema, which will appear of bright signal in the T2 and the flare. Then whenever you see a jet black lesion in the T2 and the flare, Even the fat will not appear like this. This is only blood or air. These are the only two lesions that can produce jet black appearance in the T2 and the flare, blood, acute blood, and air. And CT is diagnostic of a recent intracerebral hematoma. The exam, axial CT scan of the brain without contrast injection. Findings, no available history. Multiple foci, hyperdense, multiple hyperdense foci scattered in both cerebral hemispheres. And do you think that this is blood? This is calcium. It's very dense for being a blood, and this is calcium. Calcium around the ventricles is diagnostic of, yes, congenital intracranial infection, which includes the torch and others. Torch stands for Toxoplasma, rubella, cytomegalovirus, and herpes simplex type 2. This is T1, T2, and flare. And this is T1 without contrast and T1 with contrast, T2 and flare. Bilateral lesions are seen mainly in the white matter. You can see this lesion, which is big compared to the opposite lesion on the left side. And the lesions exert minimal mass effect, and they do not show any contrast enhancement. Diagnosis: diffuse astrocytoma or infiltrating glioma. I have said that the difference between, this is have been changed recently, the difference between infiltrating glioma and diffuse astrocytoma is that you can see the diffuse astrocytoma in the T1 weighted images, but you cannot see the infiltrating glioma. And this is no more right. Both can be seen in the T1 and also in the T2 and the flare. Both do not enhance with contrast material. Yes, it can. Both can be multiple. Metastases usually show contrast enhancement, and they are more or less well defined, not diffuse like this. Okay. Yes, this is DSA aided angiography of the internal carotid artery on the left side. What do you think? Yes, the saccular aneurysm. You know, we have many different types of aneurysms: the saccular, fusiform, oncotic, mycotic. And this is saccular aneurysm of which branch? Yes, of the middle cerebral artery. And I mean, you may say that this is M1 segment and starting M2 segment at the junction between both, but you have to say that this is very aneurysm or saccular aneurysm of the middle cerebral artery. CT, MRI flare, coronal with contrast. Pilocytic astrocytoma, they see the age of the patient. Angioblastoma. Then pilocytic astrocytoma is the most common cystic lesion with an enhancing neural nodule in the posterior fossa in the pediatric age group. It may arise in the adult, but if you see the lesion in the posterior fossa in an adult, you may suspect the possibility of angioblastoma, which is exactly similar to the pilocytic astrocytoma. Axial CT without contrast, soft tissue and bone window showing calcified lesion adherent to the inner table of the skull and a hypodense lesion in the temporal area on the right side. And this is bone. Bone. This is infarction, okay. And then this infarction does not exert a significant mass effect. It may be a subacute infarction. And what about this lesion? Yes, and I said that whenever you see a calcified lesion adherent to the inner skull table, it is calcified meningioma and not an osteoma. Osteoma will arise from the outer table of the skull, very common compared to the inner table. But a calcified meningioma is a common finding, common incidental finding, and this lesion the patient do not complain of. But the main complaint is this one. Then you may discover incidentally a calcified meningioma in a patient who is examined for any other reason, and this is known as concurrent lesion. Concurrent, yani two lesions that are discovered, one incidentally and one is responsible for the patient complaint. Axial CT scan of the brain after contrast injection, soft tissue and bone window images. Hematoma, you mean hematoma?
لا نسيت لك انت هيمي برينجيو اللي هي اللي تعتبر اجريسيف او في المنجيوم
Hemangiopericytoma. Hemangiopericytoma. Based on what? Hemangiopericytoma is a big lesion that destroys bone. Is associated with bone destruction. But here, the bone is not destroyed. On the contrary, the bone is sclerotic. Then I have said that whenever you see a homogeneously enhancing lesion that is based to the dura, the main diagnosis is meningioma. And a meningioma is usually associated with bone sclerosis. And the meningioma, which arise inside the bone, may have a component intracranial and another component extracranial. When to say that this is aggressive meningioma or hemangiopericytoma, whenever you see destruction in the calcareal bones. And this is a convexity meningioma. Yes. Yes. This has been mentioned today. Then what do you think? What is this examination? MRI of the brain, axial T2 and axial T1. Then where is the pathology? In the white matter. What is the pathology? Diffuse abnormal white matter signal. Abnormality being bright in the T2 and hypo-intense in the T1. Inside the white matter, you can see linear shadows of intermediate signal, giving the typical appearance of tigroid pattern. And this tigroid pattern is well known in two of the white matter diseases, which are metachromatic leukodystrophy and Blasius-Merzbacher disease. And whenever you see this appearance, you should diagnose metachromatic leukodystrophy because it is more common compared to the Blasius-Merzbacher disease. Okay. CT scan of the brain axial image soft tissue window without intravenous injection showing bilateral subdural collections of relative isodensity to the brain parenchyma, diagnostic of subacute subdural hematomas. Okay. Leave me alone. Yes, very good. And you see, this is an axial CT angiography of the brain showing a spider-like appearance of a vessel, a tuft of vessels in the posterior fossa, mainly on the right cerebellar hemisphere, and this is diagnostic of developmental venous anomaly, or previously it is known as dural venous malformation, and this is the wrong term. The right term is developmental venous anomaly, and this developmental venous anomaly is a normal variant, and these veins are draining normal brain tissue, and if they are treated as an arteriovenous malformation, they will result in infarction of the area drained by this tuft of vessels. CT brain, axial soft tissue window without contrast. Yes, there is a mass effect on the left lateral ventricle, which is compressed and displaced to the opposite side. And you can still see the gray-white matter interface, denoting that the lesion is outside the brain. Then the diagnosis is subacute subdural hematoma. Yes, and this is subacute subdural hematoma, which is exactly isodense to the brain. I have said that if there is a mass effect and you don't see the lesion, there are two main possibilities: subacute subdural hematoma and infiltrating glioma. The difference between both is that in the subdural hematoma, you can see the gray-white matter interface, meaning that the lesion is outside the brain parenchyma. But if you do not see the gray-white matter interface, meaning that the lesion is infiltrating the brain parenchyma, then the diagnosis at that time will be infiltrating glioma. And this is the difference. In the subdural hematoma, you see the gray-white matter interface, which is displaced medially. But in the infiltrating glioma, you cannot see the gray-white matter interface. Look at the frontal area, you see the white matter and the gray matter, and you see the interface in between. But here you cannot see because the tumor is infiltrating the brain parenchyma and disturbing the gray-white matter interface. It is an easy procedure to diagnose the lesions by MRI. In MRI, you see the hematoma outside the brain parenchyma, and you see the infiltrating glioma inside the brain parenchyma compressing the ventricle. Yes, MRI of the brain coronal scan after gadolinium enhancement. There is a lesion in the left side on the surface of the brain, showing a cystic component and an enhancing mural nodule, and the nodule is based to the dure. Then these are the diagnostic possibilities: pilocytic astrocytoma, hydatid cyst, BXA, pleomorphic xanthoastrocytoma, cystic deposit, cystic meningioma. Yes, this lesion can fit for both cystic meningioma and BXA. Both can give the same appearance. And I have said that there is one way to discriminate between both, which is spectroscopy and diffusion. In the spectroscopy, the solid component of the meningioma will show the alanine peak, which is characteristic for meningioma. I will mention this in the coming lecture. And the diffusion, meningioma will show restricted diffusion because of the high cellularity, while BXA will show free diffusion. Okay. Then this is a lesion with a cystic component and enhancing neural nodule. And this is the diffusion, diffusion weighted images and the ADC of the lesion. What do you think? Is this the BXA or meningioma with cystic component? Meningioma, because of the restricted diffusion. And this is the BXA. If you look here and you see the nodule with a cystic component, but in the diffusion weighted images, you got free diffusion. And this is pleomorphic xanthoastrocytoma. Yes. And the nodule here is not superficially located. And I have said also that many of the rules are not Quran Kareem. Right. CT, MRI T1, MRI T2 star or gradient image. Is there any history of trauma here? Yes. Few moments ago I said that diffuse axonal injury is not diagnosed without a frank history of trauma. Then if you do not have this very frank history of trauma, look for another diagnosis. This patient is complaining of headache, seizures, which is very important, seizures. Yes, and these are multiple cavernomas. And I have said that cavernoma may be so small that you see only the hemosideral ring and you do not see the core of the lesion. I said that. MRI of the brain, T1 with contrast, sagittal and coronal, pilocytic astrocytoma, typical lesion, cyst with an enhancing neural nodule in the posterior fossa. You know that this is a child looking from its. Okay. This patient, 32 years old, with AIDS. Okay, and this is flare, and this is T1 post-contrast. You got a homogeneously enhanced lesion in the right temporoparietal area, and this is lymphoma because of the history. You know that the two main lesions discovered in the brain of an AIDS patient are lymphoma and toxoplasmosis. This is angiography, selective angiography of the vertebral artery showing an aneurysm of the tip of the basilar artery, and this aneurysm contains coils. And you see the difference between the aneurysm content and the density of the artery. These are metallic coils, meaning that it has been occluded by intervention. The aneurysm of the tip of the basilar artery represents about 50% of the aneurysms occurring in the posterior circulation. MRI T2 flare diffusion, showing a high signal lesion in the central part of the bones with restricted diffusion. Glioma is a space-occupying lesion that expands the brain stem with characteristic phytic extension around the basilar artery, and this is not. Osmotic myelinolysis, central pontine myelinolysis. I have said just in a moment that Central pontine myelinolysis do not show diffusion restriction with few exceptions. Then this is one of the exceptions that the central pontine myelinolysis can show diffusion restriction. Coronal T2 of the brain. Mesial temporal sclerosis. Right?
right side.
On the right side.
في كمان البولس الجانبي.
And this is the lesion. This is the lesion. Both the hippocampi are normal, and this is the lesion. The lesion is typical of cavernoma because of the hemosiderin rim and the high signal core. I have said that brainstem glioma, the brainstem cavernoma do not present by seizures. It present by brainstem symptoms. Okay. This is T2 and T1 post contrast or maybe prayer. Okay. What do you think? Alexander disease because of the frontal white matter distribution. I mean, I have said in a few moments that if you see white matter, it changes predominantly affecting the frontal lobes, then you may think of Alexander disease. And Alexander disease is one of the leukodystrophies that can show contrast enhancement. Arachnoid cyst. Is this cyst like CSF? No? Yes, and this is the T1 axial image of the brain after contrast injection with fat suppression, showing a homogeneously enhancing lesion at the cerebellopontine angle. The lesion is extraaxial as diagnosed by widening of the ipsilateral cerebellopontine angle system. If this lesion is centered to the orifice of the interna canal and extends inside the interna canal, you may think of acoustic neuroma, which is the most common enhancing cerebellopontine angle lesion. But if the lesion is away, most of the lesion bulk is away from the interna canal and is based to the dura, which is typical of meningioma. Axial CT scan of the brain, soft tissue window without contrast injection, showing an extraaxial iso-intense lesion to the brain parenchyma, diagnostic of subacute subdural hematoma, exerting a significant mass effect. Axial CT scan of the brain before and after contrast injection, showing yes, a cystic lesion at the cerebellopontine angle, and this lesion is extraaxial because the ipsilateral cistern is widened. Then you see marginal enhancement after injection of contrast. Now diagnosis? Epidermoid cysts do not enhance. No. The most common cerebellopontine angle lesion by far is acoustic neuroma. 94% of the lesions at the cerebellopontine angle extraaxial are acoustic neuromas. And the acoustic neuromas are two types, the neurofibroma and the schwannoma. The schwannoma has a tendency for cystic component. Then, if you see a marginally enhancing cystic lesion at the cerebellopontine angle, consider cystic schwannoma. Okay, this is not an epidermoid cyst because the epidermoid cyst and the arachnoid cyst do not enhance, and this is not the site of neuroenteric cyst. Dermoid cyst contains fat, lipoma contains fat, all cannot fit for this diagnosis. Okay, we can move from this one because we do not yet have the lecture of spectroscopy. Then and you see this in axial MRI T1 and T2 and flare and contrast. This patient presented by headache, visual disturbance, and hemiparesis. He is 33 years old. Yes, this lesion is classic for an infiltrating glioma, and this lesion is also a classic for a meningioma because it is small, homogeneously enhanced based to the dura, and the meningioma, whenever it is calcified or very small, it can be incidentally discovered. It does not produce any symptoms. Then the major lesion causing symptoms is this one, which is the glioma, and the meningioma is discovered incidental.
Vein of Galen. Vein of Galen.
Galen, vein of Galen,
Aneurysm.
aneurysm, malformation. The exam is sagittal T2, axial T2, chest X-ray. And chest X-ray is presented here to show the most common presenting symptom by the patient, which is congestive heart failure. This malformation is not an aneurysm of the vein of Galen, as I have mentioned, and it is not a vein of Galen actually pathology. It is the vein which is the precursor of the vein of Galen, which is known as the median prosencephalic vein. There is a fistula between this vein and the choroid arteries, resulting in severe increase in the pressure within the vein, leading its aneurysmal dilatation. This vein is draining through the straight sinus to the confluence of the sinuses, then to the superior sagittal sinus. And because of the high flow, then you got signal void appearance, as you can see here. This is may be diagnosed as vein of Galen malformation, but you know that this is not the vein of Galen itself. Axial CT scan of the brain soft tissue window without contrast showing an extra-axial collection of mixed densities, hypo and hyperdensities, diagnostic of blood. At which stage? Subacute, because it contains both densities, the chronic and acute blood. And why the sedimentation level is like this? Because the patient is lying on his side. If the patient is lying on his back, the sedimentation level will be horizontal. But if he is lying on his side, then you got this appearance. Axial CT brain without contrast injection showing two lesions, an old infarction and acute hematoma. This is a usual finding in old age, but if you see this in a younger age, and you may think of vasculitis, as I have mentioned before. This is acute intracerebral hematoma and chronic infarction because of the negative mass effect on the ventricle. Leukodystrophy, axial T2 weighted MR images showing diffuse white matter signal abnormality with intermediate linear and spotty lesions or areas within the white matter, giving the characteristic tigroid pattern, which is diagnostic of metachromatic leukodystrophy and Blasius-Merzbacher, but metachromatic is relatively more common. Yes, a sagittal MRI T1 and T1 booked contrast. Large, homogeneously enhancing lesion destroying the bone with extracranial extension. Yes, and I said that aggressive meningioma is not usually used in this category, but you may say that this is hemangiopericytoma, which is one of the tumors arising from the meninges with aggressive characters, and it is commonly seen in males of relatively older age. Yes, you can see it's a CSF cleft sign because this is an extra-axial pathology. These are two lesions showing the value of diffusion. The lesion above shows high signal in the T2 with marginal contrast enhancement and diffusion restriction, diagnostic of abscess. And this is with diffusion free, diagnostic of okay. Yes. Glioma or deposit, the same. And this is axial T1 and T2 weighted images showing a bunch of signal void vessels representing arterial venous malformation surrounded by high signal in the T1 and high signal in the T2 representing hematoma, and a rim of high signal in the T2 representing edema. And this is an arterial venous malformation with hemorrhage. The diagnosis of cysticercosis is based on the detection of a nodule inside the cyst. Cyst with a dot sign, but if you do not see this, and you can diagnose this as tuberculoma. And then I have mentioned this. Yes, this is TB meningitis and multiple tuberculoma. Tuberculoma and cysticercosis will appear the same. The difference is in the presence of the scolex inside the cyst. If you see cyst and the dot sign, this is diagnostic of cysticercosis. So this is a CT venogram of the brain showing the vein of Galen malformation with aneurysmal dilatation and the drainage to the straight sinus, then to the superior sagittal sinus, the same abnormality we have seen in a moment. Then axial CT scan of the brain, soft tissue window, normal. آخر كلام.
لا ده اسمه كلوك ديزيز اللي بيجي فيه
This calcium is normal in the pineal body and in the choroid plexus. The only difference here is the difference in the size between the occipital horn on this side, which is a little bit attenuated. Then, yes. Okay, and this is the middle cerebral artery, which is thrombosed. In the pre-contrast scan, you do not see a significant abnormality. This may be due to the patient tilt, but in the relatively lower section, and you can see the hyperdensity of the middle cerebral artery, denoting hyperacute infarction. And in the CT angiography, you do not see opacification of the middle cerebral artery compared to the opposite side, which is opacified. Because you do not see a significant hypodensity here, and this is diagnosed as hyperacute infarction, and the best way to see this infarction is by the diffusion weighted images. You see the restricted diffusion in the infarcted area. Yes, this is a CT scan without contrast showing what looks like a vessel here after injection of contrast, and you see that this is, what is the diagnosis? Yes, an arteriovenous malformation with multiple dilated tortuous serpiginous enhancing vessels. This is a CT scan of the brain without contrast in a patient with seizures and the delayed milestones. This is calcium. Yes, because you see cortical calcification, and this is Stirp Weber. And by time you got atrophy of the affected part of the hemisphere and widening of the related CSF spaces, as well as thickening of the calvarium. And in chronic cases, you got thickening of the calvarium corresponding to the site of the lesion. Female, 18 years old with epilepsy. Which side? Right side. And this is coronal T2 weighted images showing abnormal signal in the right hippocampal area with relative loss of volume compared to the opposite side, diagnostic of mesial temporal sclerosis. This patient, 14 years old with headache and left-sided weakness. There is a cystic lesion in the posterior fossa, and this lesion is not enhancing. The patient is injected with contrast, and they exerts little mass effect. This site is for the epidermoid cyst usually, but you see the smooth margin of the lesion, which is characteristic for arachnoid cyst rather than epidermoid will have a lobulated margin, and this is an arachnoid cyst. You can discriminate between arachnoid and epidermoid by the FLAIR images, where the epidermoid cyst will show intermediate signal, and by the diffusion, where epidermoid will show diffusion restriction. This is axial CT brain without contrast and after contrast in a patient 8 years old. What do you think? There is a cystic lesion with an enhancing mural nodule. Pilocytic, hydatid, hemangioblastoma, cystic deposit, abscess. Pilocytic astrocytoma, which is the most common lesion of this criteria. CT scan of the brain before and after contrast. Yes, and this is cystic acoustic schwannoma, because there is enhancement, and the tumor is centered to the orifice of the interdigital canal, and the ipsilateral cerebellopontine angle cistern is wide, denoting that this is an extraaxial pathology. The only two lesions that are jet black in the T2 weighted images are air and acute blood. And this is acute brainstem hemorrhage, which will appear of intermediate signal in the T1, very dark signal in the T2 and the FLAIR images, surrounded by a rim of perifocal brain edema. Yes, axial brain, MRI, FLAIR, and contrast enhanced T1 weighted image. Yes, large, space occupying lesion, strongly enhancing. The glioblastoma would show heterogeneous enhancement. Meningioma is rare in the pediatric age group. Choroid, plexus, papilloma. And meningioma is actually rare in the pediatric age group unless the patient had the neurofibromatosis type 1 and you get meningioma inside the ventricle. And I have said that whenever you see edema like this in the cerebral hemisphere is due to trapment of the CSF flow in the occipital wall. And this is the classic appearance of an intraventricular meningioma, which is the most common homogeneously enhanced trigonal intraventricular lesion in adults. This represents the intraventricular meningioma occurs in the atrium of the lateral ventricle, more common on the left side, but it can occur also on the right side. And some of the meningiomas may occur in the fourth ventricle, and they are common in children if they have the neurofibromatosis type 1. Then what do you think about the tumor? Is it of poor prognosis with high rate of malignant transformation, right or wrong? Yeah, the meningioma is a benign lesion. Intense and predominantly homogeneous enhancement is seen.
Yes.
Yes. Most commonly found in children less than 10 years of old. No. No intraventricular meningioma is found in adults. Usually present with symptoms related to increased intracranial tension. Yes. Axial T1, T2, T1 post-contrast, diffusion, and ADC. What do you think? Infarction or tumor? Tumor. Which type of the tumors? Glioma. Which type of glioma? It does not show marginal enhancement. This is the contrast scan, and it shows. And this is not enhancement. It may be the vessels on the surface of the brain, and then the diffusion restriction, very mild the diffusion restriction, which is accepted for the gliomas as well. Then diffuse astrocytoma occurs at a relatively younger age, and it does not show contrast enhancement, sometimes mistaken for an infarction, but the infarction will produce diffusion restriction. DSA selective vertebral angiography showing basilar tape aneurysm, which represents 50% of the posterior fossa aneurysms. And this is T1, T2 diffusion. There is a cystic lesion capping the frontal lobe on the left side with diffusion free. Arachnoid cyst. Axial non-contrast CT head scan showing yes, very ventricular calcification and atrophic changes in a male 5 months old, congenital infection, and if you see that the calcium is intimately related to the wall of the ventricle, you may put the possibility of cytomegalovirus infection. Axial CT brain, 2 years old male, extensive white matter hypodensity, and this is leukodystrophy. The distribution of the white matter affection is almost equal in the frontal and the occipital area. And I have said, if you see this and you say you are dealing with leukodystrophy, and if you suggested that this is metachromatic leukodystrophy because it is the most common, then you may be right. As,